Chalo, wait for it. It's a great moment.
We are going live now.
A big one, yeah. It's like waiting for your first surgery. Anesthesia is
We are live now. You can proceed.
So hi everyone, welcome to our second of the series of Bombay Spine Society Fellows teaching program. The last one was on a prolapse intervertebral disc, I think lumbar disc. All of us as fellowship programs, we've known from our mentors how spine surgeries made strides because of the advances that happen in two major other fields. One is radiology and the other is anesthesia. Today we're going to discuss a bigger aspect of radiology on how and what we need to know in the MRI of the spine, which still stands to be a gold standard in most of our spinal pathologies. To help us with this, we've got Dr. Aditya Daftary, an eminent radiologist from Mumbai, Dr. Abhilash Dhruv, Dr. Kapil Mohan, and myself from the Bombay Spine Society to lead all these fellows through 1.5 hours of learning in the field. It's an interactive session, mind you. We'll start off with about 10-15 minutes of Dr. Aditya's presentation on how to read a normal MR and follow it up with specific pathologies where we'll have our fellows first run through that specific pathology and inputs from the faculty thereafter. So without wasting any more time, can I invite Aditya to share his screen and start his talk on normal MR.
Hey, hi, thanks everybody. It's good to be here. Like we said, radiology provides you an excuse for surgery. So I think it's important that you find the excuse as well. And that will be the purpose of this session, essentially. So I'm not going to waste much more time in this. I think one of the things that everybody always wants to know is how, some sort of an approach on how you can read the spine. I think one thing that everybody should remember in today's day and age, it is much better to look at electronic data than to look at films. You do all get films in your offices and people show up with films. My hope is that in the next few years, we'll be able to provide all of you with digital data to look at. So it's much better, it's much nicer, it allows you to see things. And one of the things that this helps you to do is, and I'm assuming everybody can see my screen, is that you can fix your eye on one point and scroll back and forth. And that's how you tend to see things that are abnormal more easily than if you go from one image to the next and you're sort of flipping between that. So without any further ado, let me just talk quickly about what we do or how I approach reading spines. And I'm going to start with the cervical spine, and I'm going to focus primarily on degenerative spine, but we'll talk about a few other things as well in terms of when we read. And then when we show the cases, we'll see a bunch of other things, obviously. So as far as the spine MR goes, oftentimes and most often in our country, you will see these fairly standard sequences on spine MR. There is a coronal, coronal. I'm assuming everybody knows axial, sagittal, and coronal, but just in case you don't know, a coronal image is essentially one where, let me just see if I can get you the annotations and okay, cross-reference. Okay, 1 second. Yeah, annotations. Okay, so a coronal is essentially one where you can see, you're slicing from in the coronal plane going from anterior to posterior. The sagittal is which you go from side to side, and I'm assuming that everybody knows these things. So I'm going to not spend too much time. Now we start out by doing what's called a coronal stir image. When we do a stir image, essentially the idea of this image is that we take all the marrow, we take all the fat, and we suppress it. We make it black, and we make the image completely fluid sensitive. So all fluid edema stands out bright. And I find in all parts of orthopedics, this is probably the most useful sequence to start with because it sets the tone for what you're looking at. So when you look at the coronal stir image, the things that you want to look at are, you sort of look at all the bones. So you can see degenerative endplate edematous changes very nicely. You can see the fluid within the discs really nicely. You can see that the nerve roots sheaths, so you can see these have fluid within them. So you can see the nerve roots come out very nicely. And when you get towards the back, you can see whether there's facet edema or perifacet edema, which is kind of important for all of us. When you do a patient who has trauma and you're looking for ligamentous injury, if they do just a coronal stir, sometimes it's a bit harder because you want to look at ligamentous injuries in the sagittal plane. So you want to ask them to do a sagittal stir as well. So if you're saying there's a trauma patient, the only thing you probably want to add in there, say, please do sagittal stir also to look for ligamentous injury. So once you've identified, basic fluid stuff on the stir sequences, you look for bone edema, you look for accessory fluid collections, you can see facet joint effusions, you can see perifacet edema. These are the common things that one will look at on the stir images. Once you do that, you switch your attention to the sagittal images, and we normally do sagittal T1 and T2 weighted images. The simple thing for you to remember is that T2 weighted images are the ones where fluid is bright. T1 weighted images are the ones where fluid is dark. Okay, so T1 is not fluid sensitive, T2 is fluid sensitive. And on both T1 and T2 weighted images, the fat or the marrow tends to be bright. Okay, so the reason we need to do a stir image is sometimes an abnormality of the marrow that is bright, like bone edema, will be bright on both T1 and T2 weighted images, and we won't be able to differentiate it from the adjacent bone until we look at a stir image. So that's sort of the important thing to look at that. The T2 weighted image is also very important for you to look at the spinal cord and to look at sort of cord edema or cord signal abnormalities. So, and that we count on rather than the sagittal image. We are more interested in looking at the axial images. So now on these T2 weighted images, what does one do on these sagittal images? What does one do? You start at the top. You can look for craniovertebral abnormalities. You look for if there is any cerebellar tonsillar herniation, which is important for you to find. You look at the dens itself to see if there's an os odontoideum or an old fracture or something like that that is not united, which could lead to some craniovertebral narrowing here. It's important to look here at the atlanto-occipital articulation to make sure there's no developmental fusion, because that's a common area that you can then develop problems with. And then we look at the spine itself to see whether it's straight or not. You look at the vertebral body heights. You look at the intervertebral disc spaces. Now, typically, the intervertebral disc spaces will be brighter, or the discs will be brighter than the bone on a T2 weighted image. So this is just an example of mild disc dehydration or degenerative change. And on the T1 weighted images, it tends to be darker than the surrounding fat. So that because it has fluid inside it. We can look at disc contour. We can look posteriorly at the posterior longitudinal ligament. We can look anteriorly at anterior endplate spondylosis. And basically looking at these sagittal and parasagittal images, one gets a sense for how much of the canal is compromised as a result of this disc herniation. Obviously, this is better confirmed on axial images where you slice through each disc level. This is also a very important series for us to go laterally and to look at the parasagittal images at the facet joints. And this is a great place to look for the facet joints and facet arthropathy. So that's what one of the things that I will look at in these cases typically. And then when you get towards the periphery, you can sometimes see oncovertebral spurring and lateral or lateral recess or foraminal disc herniation. So remember to look carefully at the parasagittal images for those major things. Also remember to look carefully at the interspinous ligaments and interspinous spaces, especially when you have fat suppressed images, to look for edema in these areas, because that's something that you want to look for. Now, once you've looked at this, also the bones are oftentimes better seen on T1 weighted images than on T2 weighted images. So look at both the T1 and T2 weighted images. Now, most centers that you'll get images from will just in the interest of time end up doing only axial gradient echo images. These are faster to acquire. We can get thinner images. And the other thing that these images do is they help us to differentiate from soft versus hard disk. So this sequence, because it's a little bit of a cheat sequence, if there's bone, then you get a blooming artifact, and I'll show you a case of it later on. You can help to differentiate between a soft and a hard disk. And there are other ways to do that as well. And that's something that becomes important. Now here you can see this is a very bright disk. So this is a typical, this is typically what we would call a soft disk. One of the things that this sequence does naturally, because of the artifact that it creates around bone, it tends to exaggerate your foraminal and canal stenosis. So if you think there is canal stenosis on this sequence, then you essentially want to remember to downgrade that by about 10 to 15% when you see that. So the axial images, this shows you the CSF space, the narrowing, and this will show you both foramen. You can go on the parasagittal images sometimes and see the foramen as well. Okay. So you have your central discs, you have your peripheral discs, and then don't forget to look at the carotid arteries here and the vertebral arteries. Typically, you should see dark signal within them, which is the flow void. And when that's gone, especially in your trauma cases, you've got to be particularly aware that you might have a vertebral artery dissection or a thrombus within the vertebral artery. So this would be the common things that we look at when we look at a cervical spine MR. In the interest of time, I'm going to move on with looking at a lumbar spine MR. And when we look at the lumbar spine MR, we have essentially the same thing. We have a coronal stir sequence where you can look for bone edema, especially posteriorly when you have perifacet edema or sometimes cysts. You always get a good look at the sacroiliac joints. So when you're thinking about inflammatory arthropathy, always remember to look at the sacroiliac joints. You can see the abdominal viscera. And sometimes you can see down in especially in females, you want to look carefully for things like uterine masses, cysts, in males, prostatomegaly. These are things that can sometimes become important. Oftentimes we go down and look at the hips as well, and it's not unusual for us to find a patient where you're thinking about L3, L4 radiculopathy and they have hip pain, and you find that the person actually has a subchondral insufficiency fracture or something in the hip, which is important. Again, sagittal T1 and T2 weighted images, you can see the tip of the conus medullaris well on these images. So this would be T1 and this would be T2 weighted images. Again, T2, you can see the fluid of the CSF is bright. T1, it tends to be dark. You can see the vertebral bodies. You can see the intervertebral discs are brighter than the vertebral body. And in the places where there's degenerative disc, you can see it's darker. You can see end plate changes. Remember, if they are bright on both T1 and T2 weighted images, they tend to be fatty, but they may also be edema. And if that's the case, then you want to make sure you look at your fat suppressed sequence to see whether it remains dark or remains bright. So for example, here, if we see this area here, we can double click on this to triangulate. And you see that that area does not have bright signal. It's bright on T1 and T2, but not on the stir images. So this is fatty end plate change, okay? We move on to looking at the axial images. You can see T1 and T2 weighted images. And again, here the T1 weighted images are often a great way to look for discs. They give you a sort of better sense of what the disc is doing than the T2 weighted images, which we tend to look at more often. And here you can see sort of how the disc is out. You can see the thickening of the nerve root because it is edematous and inflamed as a result of that. On the parasagittal images, look carefully for facet arthrosis. Also remember to look at your pedicles really nicely because this is where you can get pars interarticularis defects. So remember to look carefully for those lesions that are easily missed on MRI. You can see pars stress reactions, you can see fractures, and they are really, really easy to miss on an MR. So it's not unusual to miss those. When you see the disc, obviously you're going to look at central, paracentral, lateral recess, and foraminal. So if you wanted to, you would just basically divide your disc here and you'd get central, paracentral, lateral recess, foraminal, and extraforaminal. So these would be all the places you want to look for discs. You would look posteriorly at the facet joints to look for facet arthropathy or facet joint fluid. And then this over here is your ligamentum flavum. So you can see when there's ligamentum flavum thickening, you want to look for that carefully. And I suppose if you see ligamentum flavum thickening along with some facet arthrosis and facet fluid, then you've got to start thinking about an element of micro instability, which could be an issue for many patients when you see a smaller disc, but the symptoms are disproportionate to that. I also find what is very useful to look at these parasagittal images here because they are very helpful for looking at the foramen themselves. You can see small discs impinging on the undersurface of the nerve roots here. And normally what they say is this looks like a keyhole with the center of the keyhole here as a nerve root. And it's a good place to look for foraminal stenosis as well as impingement of nerve roots as they exit the foramen. The paraspinal muscles are kind of important in the back here. So when you see fatty atrophy of the paraspinal muscles, that becomes a bit important. So when you're looking at the lumbar spine or any spine, I mean, I think if you think about the process to go through, it's fairly simple. You start out by looking at marrow signal. Is it look normal? Does it look abnormal? Is it focally abnormal? Is it diffusely abnormal? Once you look at that, then you move your attention to the discs. Do you see herniations or not? Look at the facets and the ligaments. They give you a sense for whether there's instability or there's facet arthrosis. You look for edema around the facets to tell you if there could be an element of facet arthropathy, which is acutely a cause of pain. And then you look at the nerve roots themselves to see if they're being impinged by that or not. And then last but not least, go back and have a second look at the bone itself to look for past defects and things like that. And then finally, go ahead and make sure you look at the extra spinal structure, so the sacroiliac joints, the hips, etc., which are important in your management thereof. So I think that's about 15 minutes into this session. I think that's a brief overview. Is there anything that you guys would like me to talk about in terms of just approaching before we move on to cases? And by the way, with the cases, just remember, everybody, this is a totally fun thing. There's nobody's going to beat up on you. I'm just a radiologist. I hide in a dark room. I can't do anything to any of you except when I read the scans and I look at the reports and I look at what's come out. I can just say, "Oh, what an idiot for sending me this." But no, I'm just kidding. But essentially, so this is all about learning. It's all about fun. I don't think there's any silly questions in this room. If anything is bothering you, ask it. And I can assure you that somebody else would have the same questions as well. So anything else you'd like me to add before we keep moving on?
So Aditya, there were a couple of chats that came up.
Okay, let me just.
A couple of questions that the fellows had to put. I'll start off with the first one. Abhilash can take over later. There was one question from Hriday which said how to differentiate between a T2 versus an actual gradient images.
Okay, so here's a simple thing. So when we do gradient echo images are typically going to be done in the axial plane. They are fat suppressed, but we don't normally do fat suppressed axial T2 weighted images. Sometimes we do, but when you do it, the big thing that you'll see is if you see this bone here, it's very dark and it looks almost like it's blooming out. Whereas here on a T2 weighted image, you can see nicely the differentiation between the cortex and the medulla. And that differentiation is harder to see on a gradient echo image. So I think that is an important thing to do. The next is that, I hope that's clear. Yeah, the other question is on differentiating between fat-sat images and STIR. There's really no big reason to differentiate. It's just one thing to remember that we tend to use fat-sat images when we are looking at structure. Fat-sat images can give you better resolution. But the problem with fat-sat images is when you use larger fields of view or you have geometric distortions, so you have curved structures like the lumbar spine and things like that, you tend not to get as homogeneous fat suppression. So you get artifacts. So that's why we tend to use STIR images much more than fat-sat images. The other place that becomes important to use STIR images instead of fat-sat is when you have metal. So with metal, again, there are many more artifacts that happen with T2 weighted images than with fat-sat images. And diffusion weighted images are essentially images that show you mobility of water. They are helpful for a variety of things. We've used them in the brain primarily look at infarcts. We use them in the spine a bit to differentiate between benign and malignant fractures. We can use something called diffusion tensor imaging to actually explain to us the degree of mobility of water molecules within a nerve root, and based on that we can tell whether the nerve root is inflamed or not. I think a lot of these things are still very much in the research realm and not really sitting out, and they haven't really driven anything home in terms of being, wow, you have to have this in your day-to-day practice. So I would say in the early stages of your training, focus on the standard sequences, and then gradually as you get more and more involved in some functional areas, then you may want to look at more of these advanced imaging techniques.
So as the fellows go out, Aditya, and start their own practices, look at the standard images. Is there anything that you would add up? Would you say STIR is something that gives you much more than the other two? STIR is something you'll ask for?
No, so I always say start. So I say, Black Lives Matter. So start with the dark images where the fluid is bright and the bones are dark. Those are the places where you're going to be able to see the bad stuff. So if there's bone edema, if there's collections, if there's fluid somewhere, those things are where you start. So I always feel give me the easiest thing that I can start with. Show me bone edema, show me big fluid collections, then I know what we're dealing with. And then after that, move into, I think T2 and T1 weighted images after that become very important. And one thing to remember, which is very important when you're looking at cord signal, do not look at these gradient echo images for cord signal. These are images that are prone to artifact and can give you false cord signal hyperintensity. So you must look at only these T2 weighted images to look at cord signal intensity. Do not put too much leverage on these, or do not put too much weightage on a cord signal abnormality and a gradient echo image.
Yeah.
Okay. So hard and soft we will talk about later on.
Once we get into the cases.
Correct. Anything else? Anyone else? Okay, so let's crank along then, and let's not waste any more time. Everyone is
Right. So I think we'll start off with our main presentation. This is all going to be very interactive, as Aditya also has mentioned, and so has Raghu. So it's just showing you images, you guys talking us through what you guys are seeing. Very simple, very basics. No need to get confused by any of your technical terms. Just talk. It's a teaching session. As Aditya also mentioned, there are no mistakes here. There is no silly questions here. Just feel free to actually come in, ask questions, and just say whatever comes in your mind first when you're looking at all your images. So I think, Aditya, we can start off with our first case.
Yeah. Okay.
Is Yash
So-
around? Yash around?
Is Yash on? If Yash is not on, can we have some
Anyway, this is,
Tejasvi
I mean, I just
Agarwal?
wanted to show you this, right? I just want to show you. This is a T1 sequence. You can see the vertebral bodies are brighter. The discs are a little bit darker. Here's a T2 weighted image. The vertebral bodies are bright. The disc is bright also. The fluid is bright. So the disc and the vertebral body are approximately the same signal intensity here. Here, the vertebral body is brighter than the disc. And here, the disc is definitely brighter than the vertebral body on the stirred images. So this is just to show you what normal marrow edema looks like. Okay. So given that, who can I call on?
I think
Shubhanshu,
I've
you're
asked
around? Amay or Shubhanshu, one of y'all? You can. Amay, you're around?
Hello. Yes, sir.
Yeah.
Okay,
I'm
Amay.
going to go ahead.
Go ahead.
Tell me what you see on this spine MRI.
Hello.
Hello, can you hear me? Hello.
We
Hello.
can hear you, Amay.
Yeah,
we can hear you. Go ahead.
Go
Can
ahead.
you see the images?
Yes, sir.
So I'm going to ask you a very simple question: surgical, non-surgical?
That's the easiest to answer, I guess.
Exactly, right? So let's make it easy. Tell us first of all, you see anything big jumping out at you and saying, "Oh my God, I got to do something about this."
No, sir.
Operation. You see your
No,
child going to college with this case. You see a Ferrari. You see a Porsche. Nothing. Huh? None of those important things are there.
No, sir.
Okay. So what do you see? What strikes you about this case?
So this seems like a normal MRI. At alpha S1, there is hyperintense signal just in front of.
Okay, tell me which on the so tell me first the leftmost image when you're facing the screen is what type of image? T1, T2?
T1. It is a
Okay,
T1
good.
image.
Very good. Excellent. What about the middle one?
It is T2 image.
Okay, and what about the right one?
Sir, is it still?
Yes. Okay, very good. Excellent. That is, full marks for that. Now tell me, let's look back at this slide. Okay, what do you see about what does this image show you? T1 shows you see the vertebral body and see the disc. Okay, the
Yes, sir.
vertebral body is brighter than the disc, correct?
Yes, sir.
Okay, now look at this here. What's the vertebral body and the disc looking like? Is the vertebral body brighter than the disc?
So almost same.
Almost the same, exactly. So they're almost the same over there. Very good. Now let's look at the T2. Okay, here you can
Yes,
see
sir.
the vertebral body.
Yes,
And you
sir.
can see the disc. And what did we say? The disc and the vertebral body should be about the same, or the vertebral body or the disc may be a little bit brighter than the vertebral body.
Yes, sir.
Correct? Because remember, disc has fluid.
Good.
Vertebral
Yes, sir.
body has fat. Fluid is brighter than fat on T2 weighted images. Okay. So when we
Yes,
look
sir.
at it over here, what do we say? This T2.
So it is here disc is slightly brighter than the vertebral body.
Yeah, but plus minus, approximately the same. If you saw this as a regular T2 weighted image, you might say it's okay. It's not bad.
Yes,
If you
sir.
look at this T1 weighted image, you're looking at it and saying, wait a minute, this doesn't look like a normal T1 weighted image, correct?
Yes, sir.
Okay. Now let's go to the stir image here. What do you notice about this, the vertebral body and the disc?
In stir image, the disc is far brighter than the vertebral body.
Okay. Now tell me here what you see.
Sir, it is almost same.
It is almost same. So it's almost same on T1. It's almost same on stir. It's almost same on T2.
T2.
Correct? And the disc should have normal fluid signal inside it. So it basically means that this. So let's show the comparison. Here's a normal T1. Here's a normal T2, and here's a normal stir. Right?
Yes, sir.
So what has happened over here is, if you think about this, that this vertebral body has become as bright as the disc.
Yes, sir.
Correct?
Yes,
and
sir.
if the vertebral body becomes as bright as the disc, can you think of why that might happen?
Sir, it may be due to marrow edema, and the reason for marrow edema may be multiple.
Okay, but have you seen multiple vertebral bodies with diffuse marrow edema like this? Just almost homogeneously equal marrow edema?
No, sir.
No, right? So
yes, sir.
When you see diffuse bright T2 signal inside vertebral bodies or inside bones, besides marrow edema, what can it be? It's something that has, so the bright signal on this T1 weighted image comes because of fat inside the marrow, correct?
Yes, sir.
The fat inside the marrow here is replaced. That is why it is not bright.
Yes, sir.
And it is not fat inside this marrow. That is why it is not getting suppressed on the stir image.
Yes, sir.
So this means it is replaced by some cells, okay, by non-fat cells. And when it is replaced by non-fat cells, you have to think of some diffuse bony disease.
Myeloma, multiple myeloma.
Yeah, so multiple myeloma can do this, definitely in an older person. These look like they are good vertebral bodies, and an older person also you can do this. Anything else? When you say multiple myeloma, you should think of also standard.
Metastasis.
Exactly, Mets. Mets tend to be sort of blotchy, splotchy things sometimes.
Yes.
And if you think of another diffuse neoplastic bone disease, you think of in a younger person?
Osteosarcoma.
Osteosarcoma is a focal bone lesion. You think of very diffuse bone disease, something that affects all the bones almost diffusely. If you want to go to the bathroom, you say you want to go to the loo.
Leukemia.
Leukemia. Okay,
correct. So you can see this with leukemia. So this is an example of leukemia. Okay.
Yes, sir.
So, okay. So this is just important. When you guys look at spines, your focus is on degenerative disease and on focal lesions. You need to be aware of the signal changes in vertebral bodies as compared to the disc. And I think you have to remember that normally on a T1 weighted image, the vertebral body should be brighter than the disc. If you don't see that, your brain, your batti should wake up to something. Okay. And this is something that I can tell you I've missed. That anybody could miss this. Just if it shows up in a stack of things and you're just not attentive for a minute, you'd miss it. So remember, if you have somebody with diffuse back pain, diffuse bone pains, and you're not finding some major cause for it, just remember to focus on the marrow itself.
Yes, sir.
So let's just show you some other examples. So here's another example. This is somebody where you can see here the disc is brighter than, the vertebral body is brighter than the disc on T2 weighted images. On T1 weighted images, the vertebral body just has sort of heterogeneous signal, but it is brighter than the disc. And here the disc and the vertebral bodies are not quite the same, but here you know that this is actually degenerated disc because it's darker on the T2 weighted images, right? So this is just mild mottling of vertebral signal, which you would see in osteopenia. So this is what somebody would potentially call as metabolic bone disease. And this is the one where we'll tell you, please check vitamin D levels or whatever else, which you check anyways, and you don't really care about us calling that. But typically on a T1, if you see this mottled bone edema, bone appearance, then you should think about metabolic bone disease. Similarly here, when you look at this, you can see on this T2 weighted image, there's some little bit of hypointensity under the bone here. You can see on the T1 weighted image, there's a little bit of hypointensity. And when you look at these stir images, you can see there's edema in both sacral ala. So when you have edema in both sacral ala, it's on the sacral side, not on the iliac side. So it's not sacroiliitis. These are sacral insufficiency fractures, and these are osteoporotic vertebral fractures. So in somebody with osteoporosis, you can see multi-level end plate fractures along with sacral insufficiency fractures. Right? Now here's another example. When you look at this over here, this is your T2 weighted image. You can see that the vertebral body and the discs are almost the same intensity. On T1 also the same thing over here on stir. And here you can also see the same very diffuse heterogeneous signal. And this is typical when you will see diffuse metastatic disease.
Yes, sir.
Here now is somebody who's got a myelodysplastic syndrome. So the vertebral body is filled with very dark material all along. So this is a myelodysplastic syndrome. And then similarly here, when you have very, very dark signal, and that dark signal is also in the liver and in the other bones, then you can have it in something like thalassemia because of iron deposition. So this is, I mean, forget about all the rest of the stuff. I think the key thing over here is for you to just realize that when the vertebral body is not brighter than the disc on the T1 weighted images, some dimag ka batti should go off in your head that there could be something wrong with the marrow.
Yes,
and
sir.
then this is again Mets. Here the Mets are sort of sclerotic. So you can see they are black and dark and they don't have any signal inside them. And this is something you'll see in patients sometimes. So you can see these upper vertebral bodies have got a little bit of heterogeneous signal. But on fat suppressed images, they're all the same. And here the lower vertebral bodies are almost homogeneously bright signal on the T1 and T2 weighted images. And this is what happens when you see complete fatty replacement of marrow. So this is somebody who had prostate cancer, and then they have a radiation pot that goes across this whole area. And then all this marrow gets replaced by fat. So you'll see sometimes this in a patient who's got cervicalgia and they come to you, but they've also had a history of, say, previous head and neck cancer, and they've had radiation. Then you'll see this, just a few vertebral bodies in the middle looking very smoothly bright signal on T1 and T2 weighted images, but no edema in them. And that's just fatty replacement of the vertebral bodies. So this was just to show you some examples of cases where you can see very diffuse marrow changes, but just by being a little bit alert, sometimes you will pick up that odd neoplastic process and you can make a pretty significant difference to what is the management of a patient. Okay. Here's another example. Okay, so who's got this case? The second
I think Harshit. Harshit is there. Harshit, are you there?
Good evening, sir. Yes, I'm here.
Yeah,
okay,
right.
So just so you know, this is a stir image, this is a T2 image, and this is a post-contrast image.
So Harshit, can you go ahead? Now we want to start discussing surgery. The first set of them were all non-surgical, so you were not greatly excited. So tell us.
Yes, sir. So in the T2 weightage image, I can see the compression at the endplate levels of D11. The body is hyperintense on this hyperintense on stir images. So
yes.
Edema at around D11 level. And apart from
on the post-contrast images, what are you seeing?
Post-contrast image also there is deposition of the contrast at D11 level. So
there's enhancement. You don't have a pre-contrast, yes, but there's enhancement of the vertebral body rather diffusely.
Right. There's some leak over there, sir.
Well, leak as in when it's not leakage of contrast, it basically means that there is usually what happens when you have contrast uptake, it means that there is increased vascularity in that area that results in more contrast being there. Okay.
Yes, sir. Yes, sir. Increased vascularity.
So, okay. So what's the question over here?
So Harshit, what would you start thinking here? What would be a question that runs through your mind? I guess there are two things, correct? Do you want to think it's an osteoporotic fracture? Or would you want to think that it's got a pathology associated? So metabolic or pathological? That would run through your mind, isn't it?
Yes, sir.
Your
It
take?
seems, yes, sir. I would, according to me, it's more towards a pathological fracture, sir. Because there is a ballooning of anterior and posterior cortex.
Right.
In the cases of osteoporotic fractures, there's a clear-cut fracture line and there's some kind of retropulsion. But whenever there's a pathological fracture, there's like posterior convexity, and a clear-cut fracture line is also not seen. There is increased vascularity on the increased vascularity as seen
On
on
the
T and
post-contrast
T1
image.
MLS.
Yeah.
Yes,
Yeah.
sir. So I'll more go towards a pathological fracture, sir.
Anything else that would help you to seal the deal here?
Uh,
What's happening in L4?
oh yes, this. Uh,
Let's
on the
describe the signal.
Yes, sir. On the stair, it is hyper intense, so it is mostly edematous, sir. It is
So it's a
not
hyper-intense, well-circumscribed lesion
well
that is
circumscribed.
showing
Yes,
post-contrast enhancement, right?
yes, sir. So there is
So it's bright on
yes, sir.
yeah.
It is a non-contagious lesion, more towards a pathological fracture, because the osteoporotic fractures are mostly contagious. So
No,
there's
so
lesions that
basically
are
this is not a
non-contagious.
fracture. This is not a fracture. This is just another lesion in the bone.
Yes, another lesion.
But you're showing two different lesions within the bone. So let's go back and let's just talk about. Is there anything else, Raghu? Any of you guys want to discuss about this
No,
case
not
at
at all.
this
I
case?
think,
So
No, I think that should be
that's
it.
good.
okay, great. So very good. I mean, I think you nailed it in terms of thinking that this would be a malignant compression fracture. I think the key thing is when you guys see a fracture, the thing or a vertebral collapse, you have to start thinking about whether the vertebral collapse is neoplastic or whether the vertebral collapse is osteoporotic. And accordingly, your management would potentially change in terms of what you would do for these patients. So let's just look at how we differentiate these. And I think Harshit went through the points very nicely. But this is sort of a simple way in which I explain this to people. When you think of a normal vertebral body, it's like getting a box from Amazon, which is filled with books. Okay, it's a nice, strong box. If you sat on the box, nothing would happen. If you took all the books out of the box, then you're looking at what is an osteoporotic vertebral body. And if you sat on top of that box, you can imagine the box collapses, but also that you see basically the box collapses with angulation. So if you sit on it, you can imagine that box just collapsing and the side board, sides of the box just angulating. So you see angulated areas, and that's what you call retropulsion per se. On the other hand, if you had that same Amazon box, but you filled it with styrofoam, okay, you just filled it with like those styrofoam balls, and then you sat on it, then what happens when you sit on it? The box bulges, it doesn't collapse, and you get these rounded edges to it. Okay, so that's the difference between a osteoporotic and between normal osteoporotic and a metastatic vertebral body. So whenever you see a fracture with somebody who's had an osteoporotic fracture, you can see cracks in the cardboard like this. You can see that the cardboard gets retropulsed like this. So you see these retropulsed fragments, and you can see the bright fluid fracture line over here. And seeing that bright fluid fracture line is a very, very important finding that tells you that somebody has got an osteoporotic fracture versus somebody having a malignant fracture. So this is the empty box collapse. Okay. And on the other hand, this is the case that we had where you can see that here, this is, this vertebral body is almost diffusely involved by a mass lesion. And here, when you're sitting on it, you can imagine this is just a bulging box. You see the box is bulging, and you can see that dude just sort of sitting on top of it like this, right? However they sit on it, right? So you can see him sitting and it's just a bulging box. So, and this is just to show you an example of difference. So this is just that posterior bulge versus this is that retropulsion. Okay. Just again that. Now, the other thing that happens in patients who have osteoporotic compression fractures, because these vertebrae are soft, you see multiplicity of fractures, and they tend to happen contiguously because either there's an exaggerated kyphosis, and then along with that, you start to see one collapse, then the pressure goes on the next one, the next one, the next one. You see these diffuse wedge compression fractures. Whereas malignant fractures will tend to happen spread apart because The fracture of a malignant vertebral body happens primarily as a result of how much of that vertebral body is involved with the tumor. So if the tumor involves the entire vertebral body, it's more likely to fracture. If the tumor involves a small portion of the vertebral body, it's less likely to fracture, right? So here you can see somebody with a plasmacytoma with this complete collapse over here, and here you can see another metastatic lesion over here. Whereas here in this patient with osteoporosis, you can see there's, clink, clink, then one got spared because it got anterolisthesis, and then the next one went. So they tend to be more contiguous fractures in somebody with osteoporosis. The next thing that we talk about is spared marrow signal. So when you have an osteoporotic vertebral body, it's essentially a normal vertebral body. It's just lost it has normal fat inside it. It doesn't have any abnormal cells inside it. Whereas a malignant fracture tends to have abnormal cells inside it. So what ends up happening in patients like this is when you see these patients, you'll see that there's fracture, but you'll also see that there's normal marrow signal in the vertebral body. Whereas in a malignant fracture, what will happen is usually the vertebral body is entirely got abnormal signal inside it on especially T1 weighted images. So if you don't see spared marrow signal, that is something that would alert you to something potentially being a malignant fracture, as opposed to when you see spared marrow signal, that would be a benign fracture. Sometimes we can do these additional tricks where we can do what we call in and out of phase imaging that can help us to differentiate between these two. We seldom really need this, so I'm not going to go into that. Another thing that happens with these vertebral bodies is because METs tend to happen because of slow flow in the Battson's plexus. They involve the posterior aspect of the vertebral body first and then extend into the posterior elements. So when you see these posterior element involvement is something we see more often in malignant fractures than in benign fractures, but that's something we'll talk about later as well. So here you can see sometimes the hyperflexion injury, you can see that there is involvement of the posterior elements. But typically with a malignant lesion, you see the lesion actually extending into the pedicle as it does here, and you see an external soft tissue mass. So paraspinal mass is another thing that you'd see. But just remember that sometimes if you see a small paraspinal mass, this is a large one, which you can see, this is soft tissue. But sometimes you see a small paraspinal mass, which is when you have an osteoporotic fracture, you can have a small hematoma surrounding the fracture. So don't mistake that for a mass. That's just sort of sometimes a little bit of hematoma. So when we think about differentiating these things, there's a nice article, but essentially the main things are here. This convex posterior border, which you talked about very nicely. This low signal band or T2 hyperintense fracture line. Abnormal signal intensity in the pedicle is something that's important. You'll see that typically with malignant fractures. Epidural masses, you'll see in malignant fractures, and focal paraspinal mass, you'll see in malignant fractures. So these are the important things that you remember. So this convex posterior margin, the fracture line, the abnormal signal intensity within the pedicle, an epidural mass, and a focal paraspinal mass. These will be the big rules for you to remember. And I think Harshit touched on most of these very well. So hopefully most of you have understood how to differentiate these, or at least how to help yourself think about these things. Okay. So any questions on that? Or should we keep going with the next case? Let's see what other questions we have.
So Shril, you are up next.
Yes, sir.
Okay. All right, great. So
Yeah.
why don't you tell us about this case, Shril? What do you think about this case?
So the first image is T2 sagittal image, which shows L3. There's a hyper intensity in L3 in the vertebra, and in
where in the vertebra is it?
Anterior part of the.
Okay, so anterior superior end plate, correct?
Yes, sir.
Okay, so it's bright on T2 weighted images.
Yes.
Okay.
And
when something is bright on T2 weighted images, what can it be?
It can be a fluid, sir.
It can be fat or fluid. Both things will be bright on T2 weighted images.
Yes.
Okay.
And
so now what do we want to look at next?
In T1, in the same level L3, there shows a bit of hypointensity in the below the anterior end plate, superior end plate.
Correct. So if you see hypointensity on a T1 weighted image, what does that mean?
Hypointensity on a T1 weighted image means that there is some
So low signal on T1 will typically be,
Fluid.
see this CSF here.
Fluid.
Yeah.
CSF is dark
Fluid.
and this is dark. Yeah. So
Fluid.
basically low signal on a T1 weighted image is a very, very good sign of something being edema or fluid. Okay. So when you look at this, if you look at the T2 weighted image, you'll say this could be fluid or fat. When you see the T1 weighted image, you say it's dark. So this is not fat anymore. This is fluid and this is edema.
Yes.
Correct?
Yes, sir.
And now this image here.
This is a stir image, sir.
Yes, very good.
Which shows again a hyperintensity in the below the superior end plate of L3 vertebra.
Yeah. And what does that confirm for you then? That is
edema. That is a fluid.
Edema, correct. So there is edema. So fluid, think about fluid a little bit differently from edema. Fluid is actual, water or a collection or something like that. Whereas when we see fluid inside bone, then we think about more as bone edema, correct?
Yes, sir.
Okay. So now you have bone edema at the anterior superior end plate of L3. Now, what are the things that are going through your head?
Most likely a degenerative pathology, sir.
Okay, so excellent. You can have certain types of modic changes or
sir.
degenerative end plate changes, type 1, type 2, type 3, if you still go with those numbers, which I always forget. But basically, you can have edematous end plate degenerative changes. So one thing you can think of is definitely is degenerative. What else should run through your mind?
Infection.
Okay, infection can run through your mind. What else? What about a fracture? You can have an end plate fracture, right?
Yes, sir.
You can have an end plate fracture. Anything else? So now in this case, what do you think this is?
Since there is a hyperintensity in T2 and hypointensity in T1, and the end plates are fairly maintained with the disc space is fairly normal, I feel it is modic type 1 changes.
Okay, so that is definitely one way to think about it. The other thing that you'd want, so anytime you see this stuff, and these are hard cases, and that's why we sort of put this case in here, because it's one that is a very easy knee-jerk response that almost anybody would make. You'd look at this and you would say, this is end plate change, and I'm convinced this is just degenerative, and forget about it. But when you start to look at this case a little bit better, you will realize that, wait a minute, this disc looks bang normal, right? There's nothing really abnormal with the disc. When you look at this a little bit, you see there's edema in the end plate here, but you look a little bit to the side and you see what is all this stuff over here, right? This is all extra stuff that shouldn't be here, correct?
Yes, sir.
So this is stuff that sort of you start to wonder about, who the hell is this guy? So then you start looking at these axial images and you see that same level of the vertebral body, you see these little round fellows over here. Right? And you see this little round stuff here, and you see this little round stuff here. And then what would you think about?
Maybe an abscess.
Yeah, and then you start to look over here and you say, wait a minute, this anterior longitudinal ligament comes, okay. And then what the hell is this one doing over here? And then this one becomes okay again. So this is something that you should start being concerned about. So if you see end plate changes, look very carefully at the adjacent soft tissues. And when I say soft tissue, I think the idea is to look very carefully at the soft tissue. Sometimes you can see a bony end plate. So you'll see end plate spondylosis anteriorly, and that end plate spondylosis can have edema, and you can have fractured end plate spondylosis, which can produce edema. But when you see this sort of lobulated fluid collections like this, then you must be very alert for infection. And this is actually a case of infection at the end plate. Okay, so you can easily start out thinking that end plate changes are going to be just some sort of degenerative process, because we see that 999 times out of 1,000, that's what it's going to be. But what you do need to be alert is that this could be, each and every one of those could be infection. So your due diligence is to look and make sure that you don't see any adjacent collection. Is that clear?
Yes, sir.
Any questions from anybody about this case? Then we'll just go on and start looking at, or anything that the other faculty has to add about this case? And then we can just go on and show some more examples of these different things.
Sir, in case of a shiny corner sign,
So I'll show you examples of all of that now.
so yeah, okay. Just to differentiate, because that will also show
Yes.
the
So
same.
I'll show you examples of all of those in a minute. But anything the other speakers would like to add?
So I think
on
the
this case?
take-home message from this slide specifically is that most of us end up looking at the SAG, but see how different, how important it was to look at the coronal. I mean, I guess all of us would err as orthopedic spine surgeon or otherwise to not take so much of importance on the coronal, and we've all done it. I mean, we think it's the most most unimportant of the sequence, but in this one, how well it highlights. Would you all agree that it highlighted so much better?
Yes, sir.
Yeah.
Yeah.
So
I
look
think
at the
that's something
coronals. Yeah. Good.
Okay.
Anything else? Anyone else want
Nothing,
to add?
Aditya, you can go ahead.
And
Okay.
one more very important thing, as Aditya also mentioned, when we are jumping the gun saying it's modic changes, we look at the end plate and we are forgetting about the discs here.
Right. Yeah.
So you always also have to look at your normal anatomy when you're looking at your pathological anatomy, and then start making certain decisions. Okay, is it modic? Because modic essentially is degeneration, and the discs here essentially look normal.
Okay.
Sure. So we'll
All right.
yeah.
So here are some other examples of cases. So here, for example, you have somebody who has end plate Schmall's nodes. So you can see Schmall's nodes here as well as here. And you can see that there's a little bit of edema surrounding this Schmall's node. You can see a little bit of degenerative end plate edema here. You can see disc degeneration as well. So this is just an example of an exaggerated Schmall's node. Now, this can easily be mistaken for an Anderson lesion, and we'll look at some other changes again later. Now here, for example, these are more examples of your modic changes. So here you have someone where you can see, you have what looks like a Schmall's node. It's bright here on T1 weighted images. There tends to be some brightness on the T2 weighted images. There's disc degeneration. And this is a fairly classic sort of typical end plate Schmall's node or fatty modic changes. Here you can see more sclerotic end plate changes because they are dark on both T1 and T2 weighted images. So these are just different types of end plate changes. And here you can see how the disc is also abnormal in these cases. You can see these kind of conditions where sometimes you see bone edema, and you can see the edema is horizontal, sort of fairly diffuse. And this is just an end plate stress fracture. So stress reaction or stress fracture at the end plate. Here you can see sometimes you can, sort of more inferior end plate stress reactions and stress fractures. Here, these can become hard for you to sometimes differentiate infection from, from just a stress reaction or degenerative change. And these sometimes, if there's no collection, there's nothing else. These are the ones where you'll say, okay, let's not start anything, let's not do anything, but let's just monitor this patient closely to see if they get better or they get worse. But so that you prevent things from happening a little bit further down the line. Here again, now you can see this end plate. It looks like an end plate Schmall's node, but when you start to look at this case a little bit more closely, you see that there is some T2 signal hyperintensity along the posterior superior end plates. And when you see posterior superior end plate changes, those are more typical of Romanus lesions. So when you have Romanus lesions along with these Anderson lesions, then this is fairly typical of somebody who actually has a seronegative spondyloarthropathy. And when you look very carefully at the axial stir images, sometimes you'll see costotransverse osteoarthritis or costotransverse arthritis, which is essentially sort of, or costovertebral arthritis, which is essentially sort of an Aunt Minnie or a gimme or a complete, pathognomonic finding for an inflammatory arthropathy. So this is something that you should look for. So whenever you see Schmall's nodes, remember to look carefully at the posterior end plates to see if there's edematous changes, because then that can be something that would give you a sense that, oh, this could actually be an inflammatory spondyloarthropathy and not just an exaggerated Schmall's node. This is another example when you look, and we were talking about shiny corners. So here you can see that little bright T2 signal here at the shiny corners. But when you see just these bright T2 signals at the anterior corners, you've got to be a bit careful when there's squaring also. You want to find areas where there's also some posterior signal changes. So if I see just anterior signal changes, I would look very carefully at the sacroiliac joints. I would look for other areas, especially at the thoracolumbar junction, to look if there's posterior superior end plate changes or posterior inferior end plate changes. So posterior end plate changes are the ones that are more pathognomonic for an inflammatory arthropathy than just the anterior changes. So when you think about end plate changes, remember to think about modic changes. Obviously, there you're going to look at the disc. You're going to determine whether it's fatty, fibrous, or fibrofatty or sclerotic. You're going to think about Schmall's nodes, acute, chronic, just present. You're going to think about infection. You're going to look for the paraspinal collections. And when you think of an inflammatory spondyloarthropathy, think of Anderson lesions, which is like a Schmall's node. And then you're going to look for the other Romanus lesions or sacroiliitis or other signs like costotransverse or costovertebral arthritis. When you see the corner signs, the corner T2 signal hyperintensity, you can see T1 and T2 signal hyperintensity without stir changes, which is called fat metaplasia. So you can see that. Or you can see it also bright on the stir images, in which case it's acute inflammatory. So if you see a vertebral body, the posterior end plate, and you see that bright signal here, okay, this bright signal can be T1 bright, it can be T2 bright, which is usually the case, right? And when you see it on stir, you can see it bright or you can see it dark. When you see it bright, it's acute inflammation. And when you see it dark, it's chronic, which is fatty metaplasia, which indicates that something has happened. And then you can see the fractures. Sometimes end plate fractures is another thing that you'll see. If you see multi-level end plate fractures that are subtle, then think about osteoporotic fractures. Look at the sacral ala to see if you have other signs of osteoporosis. Fair enough? Any questions?
Any questions here?
Thoughts?
To all the fellows, it's an enigma. All of us still get confused at it, because imagine treating somebody empirically for an anti-cox treatment in this age of medical legal cases and otherwise. You have to be able to justify. So this is an enigma. All of us will agree that we still end up having a state of being confused as to what each of them are degenerative against infection. So any questions quickly can you think about, or we'll go ahead?
Okay, so let's just keep cranking along, and then if there are any questions, you can send them.
What happens to modic changes
so modic changes,
post-contrast?
they can vary. They can enhance, they can not enhance. So the sclerotic ones won't enhance. The edematous changes may enhance. So enhancement is not something that has been particularly helpful in differentiating modic changes from anything else. But what the contrast can do is, if there's a localized collection or something, maybe that collection will become a little bit more prominent. Now, most decent radiologists will be able to pick up a collection even without contrast. But sometimes if you want it to be a little bit more evident, more enhancing, and you want to show it a bit better, then contrast can be helpful to show you that the adjacent soft tissue is enhancing. So an example would be, if you have an osteoporotic compression fracture and you're questioning something, you can give contrast, and typically that hematoma won't enhance fully as much as a soft tissue mass. But I think that's like taking a cannon to an ant. You don't really need to do that to make that answer happen. All right.
Right.
Okay. Who's next?
Sanjeev.
Sanjeev, are you there?
Yes, sir.
Go ahead, Sanjeev.
Go ahead, Sanjeev.
Shoot.
So the second image is a T2 image, in which I can see at L4 there's hypointensity with anterior prevertebral collection, and in third image, which is a T1 image, hypointensity at L4 and L3 with prevertebral collection, and the first image is a it is a stir image. So it is a stir image which shows hyperintensity at L4, L3, and at L1 also. And there's a prevertebral collection. So
what's happening to the disc here?
And at disc also, there's hyperintensity at disc. So disc T2 hyperintensity, and in star image also there's hyperintensity, and in T1 image there is hypointense. So disc hyperintensity with prevertebral collection, it is mostly infective etiology, and disc hyperintensity most probably suggests a pyogenic infection rather than a tubercular infection.
Also look at your vertebrae above, just for description purposes.
She talked about it. It just looks more like edema inside. What do you think about this vertebra above?
So
It's
looks
very
more like a
non-specific. It could be
osteoporotic
a
or
little bit of
degenerative.
osteoporotic edema
Osteoporotic,
within it, but
Yeah, sir, because there's a chronic fracture also at
correct. And the question
at
at the
D12.
level above, yeah. And the question over here
Yes.
is always is when you see this, is this disc or is this vertebral body related to what's going on over here? So do you think this is related to this? You think
So-
this and this have anything to do with each other?
So usually, sir, in pyogenic infection, it is contiguous involvement, not the skip.
Correct. So
involvement.
I mean, basically, when you see this, the question is that whenever you see a level that is majorly abnormal and you see other levels that are
Yes.
abnormal, your question always in your head should be, is that, are these other levels that are abnormal related in any way to this? So for example, if this was metastatic disease or this was a tumor or with this TB or something like that, then you would say that, well, I can see multiple other vertebral involvement, which could be the same disease process involving other areas. But when you see this, this seems like it's unrelated to this.
Yes,
Right? It's just sort
yes.
of you seeing sort of incident. So very
Yes.
good. So this is excellent. This is a case of pyogenic discitis, pretty classic. And you know, this is sort of what you see. Now, here is another example of somebody who's got, in this case, you can see this whole collection and disease here sitting down at the sacrum. You can see this large collection here. Oftentimes on these T1 weighted images, what you'll end up seeing in TB, you see it in pyogenic also sometimes. You see this here on this T1 weighted image, you can see the margins of this on T1. The T1 margin is bright. Can you see this? You
A
can see
bit bright, yes.
Yeah, so some people say when you see T1 bright margins, it's somewhat of an indicator of tuberculosis. You see it in other conditions as well. You can see it in pyogenic, and you see it sometimes. So this is a case where, again, now you can see this collection is larger. It's almost eating up the entire bone. It's extending into the bone much more, and this is more typically tuberculosis. And along with it, you can see this edema here in this vertebral body as well. So, you know, there's other non-contiguous vertebral body involvement. So what are the primary discriminators, distinctive factors between tuberculous spondylitis from pyogenic spondylitis on MRI? So if you see well-defined paraspinal abnormal signal, then that is something that tends to be more with TB, because TB you get collections, whereas with pyogenic you tend to see more of inflammatory change around it and not so much of the fluid collections. If you see thin and smooth walled abscesses, that's something that you'll see typically with TB. I think all of you have seen enough of those. A paraspinal or an intraosseous abscess is something, again, that you'll see more often with TB. So you can see that. You can see subligamentous spread. So when you see disease sort of tracking along the subligamentous region like it does over here, right, that's something that we see fairly typically with TB. If you see it spreading along multiple vertebral bodies, again, you see that with TB. And you see multiple vertebral bodies being involved, then again, you sort of think of TB. So those are the primary discriminators from tuberculosis versus pyogenic spondylitis. There's some role of PET-CT as well. But I think all of this is moot in our society, correct? This whole thing of MRI being used to differentiate between tuberculous and non-tuberculous, is that something that's important for us? I don't think it's that important anymore, because now we're in a situation where we have so much of drug-resistant TB that we really need to be biopsying all these patients. And the time to biopsy all of them is the first time you see them. There's no point in starting empiric and saying, oh, then we'll see what happens and then we'll decide, you know, what to do about it. I think the time to biopsy them is initially. The key things that you're going to look at MRI is on terms of where is your best yield for biopsy. Are you going to go after a large collection? Are you going to go after a piece of bone? And if you have a small area that you're really concerned about, where it's just near the end plate, your maximum yield is going to be by scraping the undersurface of the end plate. So that's where you really want to get tissue out of. So I think with TB and RCT, and again, I'll ask my other speakers to chime in for this. I think it is imperative for us to be doing biopsies on all of these patients before starting them on empiric TB, because we've just seen way too many patients were put on empiric treatment, not changing. And then once you start to try to biopsy those patients after that, it's a nightmare trying to get a positive result.
Yeah, I think all the fellows, I think at least Mumbai fellows, it's drilled into their heads to biopsy
Right.
all of these. So
Yeah. So great.
they're spreading the message.
Yeah. Okay. All right.
So we have Shrikant for case 5. Shrikant, are you there? Shrikant?
Silence of Shrikant. Wait, anybody else?
Anyone,
Abhilash, you can
anyone.
continue. Yeah. If
Sanjeev,
anybody
you can continue.
Yeah.
Yes.
Sanjeev, you're there, no? Continue with this one.
Yeah, yeah, sir. I am here. Once, yes.
Harshit? Yeah.
Yes, sir, I'm also here.
Yeah, so both
So
of you can
anybody,
contribute.
just what do you think of this case?
There's a collection, sir, on the right side from L2-3 disc space going posteriorly and abutting the chordoid quina at that level. I can see in the right fourth image. And is a post-operative
Yeah, so there's a bone
image.
defect,
Yes,
right?
there's a
Back here.
bone
There's a
defect is
bone
there,
defect
so it is
here,
a
right?
post-operative collection. Yes, sir.
Correct. So now when you look at this post-operative collection, what would you think about? This is the T, if we think about this is the T2 weighted image. This is the stir image. This is T2 weighted image. This is T1 weighted image. So
Sanjeev and Harshit, what are the two things post-op you would want to rule out? I mean, if you look at a collection, what are the two collections?
So these kind of things are first, sir, hematoma, and second is infection, sir. Two things.
Okay, good.
I would like to rule out.
Okay.
Yes.
What else? One more.
One more, yeah.
Pus, you said, hematoma, you said. What else?
When you go
One
to
thing
Italy,
which we really don't
you
want
go
to
see
see.
the capital.
We don't want to
which is-
see.
CSF.
Sir, CSF collection. Yes.
CSF
Correct.
collection.
So these three are the main three things that you're worried, no? You are looking
Yes.
at immediate post-op. Yeah.
Yes.
So when you look
Right.
at this, what are you thinking about? Which of these three is more likely? So when you see
Sir.
this, when you look at the signal that is inside it, it's very heterogeneous signal, right? It's hazy signal. It's
Yes.
not like it's a discrete circle in which there's bright signal that is like CSF, correct?
Yes.
So it's not a collection. It's not. I mean, it's not a simple fluid containing collection. So it's definitely not CSF. Correct.
Yes. Sir.
And
Mostly-
when you see infection, also you can see if it's an infection, it's not got a thick wall with a central liquefied area. So it's not an abscess. Could it be phlegmon? Possibly. You would depend on whether you're seeing this early. This was probably day 1 post-op. And when you look at it, it's got the T1 signal is a bit dark, but it's also a little bit hazy, right? It's a little bit on the brighter side. And here the T2 signal is also bright. And this heterogeneous signal that you see is more commonly going to be seen with an. So it's
What's left?
Blood
Ruled out,
Hematoma.
right?
Yes. Epidural hematoma. Yes.
correct. Correct. So here it's a moderate collection. We don't know if we can drain it really at this stage with a tube, but you have to go and openly remove it. It's extra spinal. It's extra dural. It communicates with the epidural space, and its signal characteristics signify that it is probably a hematoma. Okay. So let's look at some other examples of some postoperative collections. So here, for example, again, you have fluid signal, which is rather narrow. So this is just sort of your postoperative fluid tract that you can oftentimes see fluid along. And that's just a small little postoperative seroma. So you can see a non-drainable extraspinal postoperative seroma. You can see something that's much larger like this, more discrete. You can see all the thin wall that's along it, right? And again, this is an example of, these are all examples of drainable postoperative seromas. There's no communication with the thecal sac per se. These are all extra spinal collections, right? And here is another example. You can see this sort of fluid collection here, but when you see where it is right along the nerve root, right? And this is an example of somebody with a pseudomeningocele. So this is post-operative pseudomeningocele over here. You can sometimes see these collections that can, post-op collections that can sort of wax and wane. So this was sort of January 2018, then in 2019 it became this big, then again later in 2019 it became smaller, and then finally it vanished. So some of these post-operative seromas, and especially even post-op TB cases, you can see collections wax and wane. You basically want to look at the vertebral bodies and what is changing in those. So you can have these collections varying in their size over time. So here again, you can see how these collections have just changed in their time, their size and appearance over time.
So Aditya, in that previous slide where you've shown metal artifacts, in such a situation, how do you determine that this is just a post-op collection and not,
So
I
if you
mean,
see
it's
this,
case of tuberculosis?
So if you see this over here, so that's why again you need comparative images always. Those are very, very important. And when you see this, the collection, the wall is very thin over here. It's not a thick wall. So when you see the slender wall, it's usually resolving. When you see them, you'll end up seeing a lot more bone edema and a lot more sort of shaggy, irregular tissue inside this when it ends up being active TB.
Okay. So would you actually put a contrast in this just to discern between?
You might, but oftentimes you don't need it. Most places by default will give contrast because you want to see enhancement of something else somewhere else. And oftentimes with the magnetic susceptibility artifact, it may be harder to see. But in these situations, because they are challenging, because you have the patient in the scanner, you will do everything because later on you don't want to say, oh, now I don't have something to do something. So very often you'll find the answer without contrast, and most often the contrast is not adding anything. But given the situation, given the decision, all those things, you want to make sure you cover all bases. If there is something that
these regions will not enhance. So one way to say
you can have, but what you will typically see is slender rim enhancement. If you see slender rim enhancement, we're not worried. Where we start to get concerned when we start to see thick, shaggy enhancement, because then we know that's active tissue.
Right.
So this is not, this is just, this is like smooth, thin-walled septate collection. So this I'm not so worried about at all, at any situation.
Perfect.
Okay, here's another one now. In this case, what you can see is, again, you have fluid, you have it here, and you can see on post-contrast, there is enhancement, and you can see this enhancement around this as well. You can see edema at the vertebral end plates, which is enhancing, and you can see enhancement around this area right here, which is essentially this thing. And this is essentially an epidural abscess with peripheral enhancement. So this is a different type of collection where you see, and here coming back to your question, is in terms of, you can see this thick, shaggy enhancement. This is not that smooth, well demarcated wall that we were talking about earlier. See, here you would see this looks a bit thin over here, and this looks a bit thin here. Here you're not seeing it, but here when you see the enhancement, you can see how it's this thicker, shaggy, heterogeneous enhancement, right?
Yeah.
And then here again is another example of a large epidural collection and epidural abscesses. So these are the other things you'll see. This is one of the things, and this is out of the literature because we don't see as many of those, or we don't actually have to image as many of those, is when you're looking at CSF leaks. So here you can do an intrathecal injection of contrast, and then when you see leakage of contrast into the epidural space here, then you know that this is somebody who's got a CSF leak. And then oftentimes you can look very carefully and you can actually find the point of the leak also when you do these studies. This is an example. You can see sort of expansile extradural lesion over here, and this is a postoperative arachnoid cyst. So in general, when we look at collections, we try and determine whether it's simple liquefied fluid or it's heterogeneous, whether it's a phlegmon, if it's drainable or not drainable, and if you have previous studies, whether there's interval change. When we look at the location, we try to determine if it's intra or extraspinal, if it's intra or extradural. We look at communication with the thecal sac, oftentimes in post-op cases, we're looking at communication with hardware. And then we want to characterize this, whether we think this is a seroma, or this is infection, or this is just a hematoma. And sometimes contrast can be helpful, but I think oftentimes it's the heterogeneous signal within and the nature of the walls of the lesion that are a better guide to what kind of collection it is. Clear, everybody? Just from the basic approach to postoperative collections.
This is very important to know because evaluating your post-op MRI, these are the things which you should always know, and differentiating factors. Very important.
All right.
So any questions here? I think we can move on to the next one.
All right, great.
I'll call on Pratik.
Yes, sir, I am there.
Sure.
So these are two different cases, Pratik.
Yes.
The case on the left and the case on the right. And these are both T1 weighted images. And the question over here is this post-op radiculopathy, is this disc or scar? So the case on the left, do you think it's disc or scar? And the case on the right, do you think it's disc or scar? And you can always be a good radiologist and you say, I don't know, I still need to do something more.
Sir, I need post-contrast images to see.
Okay, so fine. So here's post-contrast image on this one.
So usually the left side is the axial cut of T1 and post-contrast images showing there is peripheral enhancement in the right side foraminal region.
And
it's,
that's like a radiologist answer. There is peripheral enhancement. So what is the question? So what is the answer?
Means it's
Pratik, why is it important? Because if it's this your primary surgery, you want to call it scar. If it's somebody else's primary surgery, you want to call it a disc.
Correct.
So that's how our practice is going to be. It's very important.
Yes.
And as a radiologist, we always ask this question first to the surgeon when they send it to us. Did you do the surgery or did somebody else send it to you? Then accordingly, we decide on the reporting strategy.
No, jokes apart, I think it's important, Pratik, because you're trying to play a hero here and you want to think that it's a disc, go in, do something. But actually, you don't want to make a fool of yourself. You know, you're trying to prove a point. So I think, yeah, so go ahead. Sorry.
So what do you think this is?
Sir, it's usually in post-operative scar, there is non-contiguous involvement with the disc and there is a homogeneous enhancement.
So what's your answer here? You're still sounding like a radiologist.
Pratik, disc or scar?
देखो बॉस, तुम मेरे सर पे आके ऐसा ही पूछता है, डिस्क की स्कार है, डिस्क की स्कार है, डिस्क की स्कार है,
सर स्कार, पोस्ट-ऑपरेटिव स्कार.
हाँ, बस ऐसा मटका मारो. चलो, very good. Okay, what about this one?
So it's there's peripheral enhancement in the post-contrast images on the right side, so it's recurrent disc.
But here also you said peripheral enhancement.
That's a homogeneous enhancement. Sorry, sir. Left side is homogeneous enhancement.
Okay, good. Very good, actually. So this is true. This is all this scar tissue that you see over here. No? All this area that's dark. You can see the whole area is enhancing, right? And yes. So this is all going to be post-operative fibrosis. Whereas here, when you look at this one, you can see that there's enhancement for some of this. So this is fibrosis, this part here. But this area over here, this specifically, this rounded area here, you are seeing this peripheral enhancement to this rounded area. And this is the central disc component. Okay. So this is your donut sign that you see. And this is post-operative disc. So this one is going to be disc and this one is going to be scar. Okay. So everyone clear about this? So
any questions? Anybody?
And all of the cases are not necessarily this clean in terms of seeing, but this is sort of a way to really establish it very clearly. Okay. So now
also remember, I don't think it will be purely isolated and black and white. There are going to be those gray zones.
You may see it better on the axial. Sometimes you may see it better on the coronal. Sometimes you may see it better on the sagittal. Sometimes. So we do get post-contrast images in multiple planes because it really helps us with what is going on. Now, other things that you can see with perineural enhancement. So sometimes you can see a textiloma. So like a small pellet or something that was left behind can have enhancement like this. And sometimes you can see postoperative gas that can also have this sort of peripheral appearance. So here the CT is sort of helpful in differentiating gas versus being, actually a component or some soft tissue lesion or nodule. So gas is sometimes hard to tell on MR. Sometimes you'll see an artifact with it, sometimes you won't. So you want to be a bit careful with that. So just remember, these are some other things that you should run through your head every now and then. That could it be gas? Could it be a foreign body of some sort? Okay. Anything else? Should we keep going?
Yeah, I think we should go.
Okay. What about this
Rajendra.
one?
Aditya, hi. Nikhil here.
Hi. Yeah, bolo.
Sorry. So I just wanted to ask for the post-operative scans.
Yeah.
When is the contrast to be given and to be its utilization is the best? Immediately, within 3 months, and within 1 month?
Depends what your question is, no?
So if you're suspecting it to be a recurrent disc or maybe some
recurrent disc is usually going to, if you're,
material
I mean,
left-
basically whenever you feel the symptoms are there, that's when you will give the contrast, because it will help you you will always see some post contrast enhancement even post-op. And then the challenge is just differentiating post-op change from disc. But disc versus scar, the question can be answered at any given point in time with contrast. You can give contrast anytime. So even on day one, we give contrast.
So ideally, post-op immediately, if you want to get a scan, a contrast scan would be better. Immediately within the first.
Ideally, the time to do a scan and to give contrast is when you're trying to make a decision on whether you should operate or not operate.
Okay.
So you tell me that you want to wait 3 months and then take a decision on whether to operate or not operate. You do it around that time. You tell me it's day one, the patient has excruciating pain. I need to know if it's disc versus something else that's there. Then you do it on day one.
Okay.
Do it. The time to scan is the time that you're planning to do something about the results of the scan. So I always say when you scan, you always ask the question. So when you ask for a scan, always ask for a scan with a full idea of what are the answers that are going to come back and how is that going to change your management. If you're doing a scan just for the sake of doing a scan, I'm very happy because that's just money in the bank. But from a patient perspective, it's what are the results of that scan that are going to make you do something different. So let's just say, for example, you have a post-op patient who has pain, but the pain is not bad.
Right.
And so you say, this could just be
it all
post-op
depends
pain.
on the
I'm not
level
going
of
to do
treatment.
anything about
Yeah.
it.
Okay.
Then there's no point in rescanning the patient at that stage.
Exactly.
The day you say, okay, no, the pain is bad, it's like 8 out of 10 or 9 out of 10, and it's been going on for the last couple of days, and the patient is really eating my brains. I really should figure out whether there's something major, or I just need to reassure the patient that things are okay. Then that's the day you do the scan. Okay. And your decision in your head is, on the scan, tell me, is it something that I need to operate for, or is it something that I can just reassure the patient that, look, man, this is just post-operative change. It's going to take a little while. It's going to go away.
Perfect. Okay. Yeah. Thanks.
Okay. All right. So here's the next case.
Gajendra.
Yes, hello.
Bol.
Sir, there is a compressed fracture vertebra seen with a retropulse fragment in the compression on the spinal canal, and there is also some signal changes in the posterior interspinous space on the second image and the first image.
So you're talking about what changes here? This stuff? Or this stuff here? Circle or arrow?
That is
or something else?
No. Arrow, sir.
Arrow. Okay, fine. All right. So anything else? Anything else you'd like to say about this? Anything else you see? Why the other images are given?
No.
Okay. So again, I think we are probably running low on time to some extent, but the idea really here is that when you see this vertebral compression fracture, the natural instinct is to just say, look, is this osteoporotic or is this a malignant compression fracture? And the issue over here, I think you rightly pointed out that there are some changes here in the posterior elements. And when you look really carefully over here, what you can see is there is, as compared to the other facet joint, there is some facet joint widening here. And when you see this facet joint widening along with all of this stuff, here's the axial image, and you can see again that this facet joint widening. The idea really here is that this is a hyperflexion or a chance injury, and you have posterior interspinous ligament involvement as well as vertebral compression. So this is a hyperflexion injury, which is like a chance fracture. So just to keep your mind alert that when you see vertebral compression fractures, now oftentimes you guys have the history, so you know what it is. For us, we just get vertebral compression fracture, please deal. Tell us what you think. One may forget to look at the posterior elements, one may forget to think about these things, and sometimes these findings can be a bit subtle. So like in this case, if you look at the posterior thickened posterior interspinous ligament, it looks quite good over here. But if you look at the the interspinous ligament in this area, then there's definitely some edema. And then when you reinforce that with widening of the facet joints, then you know that there's definitely been a 3-column injury. So this is sort of was the main basis of showing this case to all of you. Is everyone clear about this? So here, I think the key things are that you look for the vertebral wedge compression fracture anteriorly. You look at the widened posterior interspinous space with or without edema, facet joint winding, and you want to remember that it's a 3-column unstable injury. And this is your example of your typical osteoporotic wedge compression fracture, where you see the wedge compression fracture, but you see the interspinous distances are actually not really affected. There's no edema, and this is all just that particular vertebral body that is affected. Okay, now what about this one? Anyone?
Hriday.
Yes, sir.
Hriday, are you there?
Yes, sir.
Yeah.
The first image is a T2 weighted image, and the second is a T1 weighted image. It shows continuous narrowing of the cervical canal stenosis with continuous narrowing, which is most probably an ossification of the posterior longitudinal ligament.
My diagnosis is that
Yes.
orthopedic surgeons know how to read.
Yeah.
Okay, cool. So this is a case of OPLL. It's just that oftentimes one reads the discs and then forgets to look at the posterior interspinous things. And you can see here again how on this image you can see all this stuff blooms, and you can see how this is all exaggerating the degree of canal stenosis on the gradient echo image. So this is OPLL with cord compression, and you can see there's thinning of the cord and there's edema within the cord, which is all in keeping with myelomalacia. Now, this comes to the question that everybody has been awaiting with bated breath on how to differentiate in hard and soft discs. So here is an example where you can see at C4-5, you can look and you can see here on the T1 weighted image, you can see the vertebral margin very clearly. Here also you can see it very clearly. And here you can see the disc within it. Here on the T2 weighted image, you can see the disc coming out. On the CT, you can see the bone quite nicely under it, and you can see soft tissue sticking out here. So this, when you look at this also on the gradient and the T2 weighted images, you can see it's bright signal that's coming out. So it's dark with a little bit of bright signal on the gradient echo and just dark disc on the T2 weighted image. And this is pretty typical of a soft disc. Now, as opposed to when we go down and we look at this at the level below, which is C5-6, what you can see here is how you see how this vertebral body ended here at T4 like this, as well as here at T5 like this. Whereas here, when you see it, you can see it is coming out more like this. So it sticks out a bit like this, right? And similarly here, it does the same thing like this and like this, okay? And when you look at the gradient echo image, it's more like flat, diffuse, broad-based. Here it's flat, diffuse, broad-based. And if you look also still further back, you'll see that there's cortex here and then there's a high signal. So there's a low signal band of tissue over here, which if you go back one image, you don't see that same low signal band over there. Okay, you can see this is a bony margin. And when you look at the CT, you can see the end plate spondylosis here. So this is something that would be more of a hard disc. So if you look at a combination essentially of the T1 weighted images, which show you a good estimation of the bone margin, and the gradient echo images, then that gives you a good way to look at whether something has got a hard or a soft disc. Does this make sense to all of you? So then the other thing that we wanted to talk about here was that when you see cord signal abnormality, you have to look at the T2 weighted images, and you can see everything from subtle streaks like this, which could just be like this prominent central canal. You could see more diffuse high signal. You could see diffuse high signal with expansion of the cord. You can see focal high signal within this, and then you can see narrowing, and like in our case with myelomalacia. And when we see cord signal abnormality, we want to look at the T2 weighted images, not the gradient echo images. When we think of cord edema versus myelomalacia is chronic. It tends to be thin the cord out a little bit, and it tends to be sort of more over a short segment oftentimes. And you want to be careful about misinterpreting cord edema from myelomalacia, because myelomalacia is an irreversible process, whereas cord edema is a reversible process, right? So there are many specific ways on looking at cord signal, and depending on the distribution of the cord signal abnormalities, one can decide on whether they are neoplastic, demyelinative, degenerative, infectious, or infarcts. The key ones that you will remember are the ones where we see this in the sort of anterior aspects of the vertebral bodies, where you see this snake eye appearance. And this is something that you will see in infarcts or in compressive myelopathy. You'll see peripheral lesions in things like MS and in demyelinating processes. In transverse myelitis, you'll see more diffuse areas, and then you can sometimes see irregular things in hemorrhages, tumors, and trauma. So remember that cord edema is there. They're very standard patterns of cord edema that you should probably go and look up at once. What about this case here? Anyone? Quickly, what time is it, guys? Just I'm on my watch.
We can just make this our final case.
Okay, so let me just go through two quick cases because I only have 2 or 3 more, so I'll just go through them quickly. So this is one where you sort of see this L12 disc, you think there's a small disc here, you start scrolling through this, and as you keep coming down, oftentimes you've got to look very carefully on these sagittal images, because if the tech also didn't see it, they didn't get axial images, we tend to get images like this at this level, then we'll do at this level, then we'll do at this level. So if they didn't see it on the sagittal images, you might miss this extruded or sequestered disc, which you can see right here. So remember to look carefully at the parasagittal images for extruded and sequestered discs. This is particularly important in those cases where you look at the spine initially, it seems like, oh, everything is clear, it's a good spine, I don't know why this person has radiculopathy. You've got to look carefully for these little things on the parasagittal images. So this is sort of giving you those few cases where you start to look at these cases from a standpoint of, I'm not seeing much on the scan, where else should I look? Okay. That being said, the other one that you're going to look at is, say, for example, in this case, you see these large discs, they are mostly right-sided, but the patient has left-sided symptoms. And when you look at it carefully, you see over here that at the L4-5, there's an extra foraminal disc, which is actually impinging on this L4 nerve root. Here is just in close proximity, it's not really impinging on it. And here it's not anywhere near it. So even though you have primarily right-sided discs, the patient's symptoms are more left-sided and relate to L4. So remember to look very carefully for extra foraminal discs on the axial images. You can also see these well on parasagittal images like I showed you earlier in the normal section. And this is the final case where here you can see this small little cystic structure that is extending down from the facet. It's a facet cyst from facet arthrosis. And this is a case in which we actually did a CT-guided facet cyst rupture. So we put a needle into the facet joint, injected the facet joint with contrast, opacified the cyst itself, and then we sort of ruptured the cyst, and we brought another needle through the interlaminar space right into the cyst, and then ruptured the cyst, and you can see the leakage of contrast into the epidural space. So this is how we managed a facet cyst. So with that, I guess we'll stop the session and take any questions.
There's one question that we need, somebody's asked before we wind up. Can we look at a root abnormality, double roots or conjoint roots on an MR? It's a tough one for all of us, but
I don't think I have an example of that ready available.
Yeah,
with
great.
me. So unfortunately, I don't have that ready available. I used to have one, but yeah, sorry.
So any more questions about MRIs that you guys would be having right now? This is the time to ask before Aditya disappears.
Like all good radiologists, when you really need me, I will vanish.
Yeah, but see, you didn't yawn today. See,
I
as
did
per our
not yet.
discussion. Yeah,
I'm
so
working on
we
it.
kept you interested. All the fellows, any questions that you need to ask? If not, then we can wind up the session today. Yeah, so the fellows are saying thank you to us. Yeah, okay,
had
great.
enough of
Okay, great.
The fellows are all bored. So thanks a
Everyone's
lot.
gone asleep now.
Thank you for taking our time out to
Thank God.
educate us spine surgeons and our fellows. And thank you to all the fellows for attending and participating. It was a good interactive
Yeah.
session.
Great.
I thank our faculty and the conveners and the Bombay Spine Society.
Okay.
Thank you, everyone,
everybody.
and have a good night.
Yeah.
Night, everybody.
Thank you, Neeraj.
Thank you, Neeraj.